Good afternoon. So, are we ready? Okay. Thank you so much, all of you, for being here. I think this is going to be a very exciting session. And I think it's extremely important that STS put this session together. And it's extremely honored, at least for myself, and I know for Dr. Chen here, that we're moderating the session. My name is Rania Prevenza. I'm at Baylor, and we do a fair amount of TAVR cases on high risk, low risk, and intermediate risk. So I think this session is going to be extremely important, and we're looking forward to. And please feel free to come up and give us any questions and make this session really exciting. Dr. Chen?
Thanks, Rania. You know, the point of the session is to go over the low-risk TAVR trials, but also to provide some alternative viewpoints. And hopefully at the end of the session, you will find that we've had a balanced overall perspective. The intent was to have all the talks given and then have a robust discussion period at the end. However, Dr. Reardon does have a prior commitment at 2 o'clock. So after his talk, we'll have 5 or 10 minutes for questions, and then have the rest of the talks in a row, and then at the end we'll ask all the speakers to come up and have a 30-minute free discussion between the audience and the speakers. So our first speaker is Dr. Michael Reardon, who needs no introduction. He will be discussing TAVR with the self-expanding valve in low-risk patients, results of the Evolute trial.
So Ed, Rania, thank you very much. Thank you for coming. As I said, I'm Michael Reardon. I'm a cardiac surgeon from Houston. It's really my pleasure to present this on behalf of my co-PI, Jeff Popma, and our low-risk investigators. Here are my disclosures. And I was the PI, so I am somewhat involved in this trial. So our background, we ran a variety of trials. We started with a high-risk trial where we randomized with a primary endpoint of all-cause mortality against surgery. We were actually superior at year 1 and year 2, but by year 5 there was no difference. We ran an intermediate risk trial for TAVR. We used a Bayesian analysis to get a 2-year endpoint of all-cause mortality or disabling stroke, and it was non-inferior at 2 years. We've actually presented the full 2-year data, and that manuscript is winding its way through and hopefully will be out soon. But it showed no difference from the Bayesian analysis. So the objective of the low-risk trial was to assess the safety and efficacy of TAVR with Evolute self-expanding supraannular valve compared to surgical AVR in patients with a low predicted 30-day risk. And we defined that as a predicted 30-day mortality of 3% or less. This is a study administration. These are the sites that participated in the low-risk trial. It was truly an international trial, including Australia, New Zealand, Japan, and Europe. And the study design was we looked for patients that were low risk by our definition. They were seen by the local heart team. The local heart team said they had met all the inclusion-exclusion and met all the anatomic criteria for both TAVR and surgery. Then they were sent to a national screening committee where eligibility was confirmed. Of note, at that level, 14.8% of people were screened out after local eligibility. If they were accepted at the national level, they were then randomized 1-to-1, and they were stratified by the need for revascularization. Both arms will be followed for 10 years, and both arms have a leaflet thickening and immobility substudy. We'll present our 1-year data at ACC this year. Now, the primary safety next endpoint was all-cause mortality disabling stroke at 2 years. When Gilbert talks about Partner 3, we can talk about the different endpoints and why we chose different endpoints, but we thought that this was a more solid endpoint that wouldn't be influenced by physician decisions, so we decided to stick with this. But because of that and it's low risk, we needed more time, so we went with a Bayesian analysis. We had hierarchical powered secondary endpoints, looking at flow and looking at quality of life, and then we had a number of secondary endpoints that had to do with safety that you can see. The key inclusion criteria is pretty much what we expect. You had to have a small valve area, and you had to have a mean gradient or velocity over 4. You could be in if you're asymptomatic, if your velocity was over 5, if your EF was less than 50 and you made it by dobutamine, or if you failed a stress test. All these were guideline indications. Now there's some key exclusion criteria. If you had a contraindication to a bioprosthetic valve, you couldn't be in this. If you had to have a mechanical valve, you weren't available for the study. But we eliminated multivessel coronary disease. We eliminated syntax above 22. Gilbert will tell you a partner was 33. But if you look at it, we'll talk about it in a minute, the syntax in this trial was only 2. Even though with 22 as our limit, we did not treat people with coronary disease, and we eliminated all bicuspid valves. There's also a key exclusion criteria of excessive calcification. That's really poorly defined, but something that existed in both trials. Again, we use a Bayesian analysis that allowed us, when 850 people hit 1 year, to do an early look at this. And that early look, if we were under a non-inferiority margin of 6%, with an area under the curve of greater than 0.92%, that meant we would win and we could actually do data analysis. We had the power for the study was 1,200 patients. We ended up randomizing 1,468 because we had to finish the leaflet thickening and immobility sub-study for the FDA. The as-treated group will be our analysis. If you notice, there's a number of crossovers and dropouts, particularly on the surgical side. A number of people dropped out when they did not randomize to TAVR. And even after they randomized, there were several dropouts in either direction. The implanted group will be used for the echo analysis. The primary endpoint will be the as-treated group. And again, 14.8% screen failed at the national level. Now, we didn't use a single valve. We had 3.1% original core valve 31s, about 3/4 second generation Evolut R, and about 22.3% third generation Evolut Pro. These valves were being introduced as the trial went on. We did not have a demand that you be transfemoral like the other trial, but even though so, 99% were transfemoral, 0.6% were axillary subclavian, and 0.4% were direct aortic. As we move to the results and look at the demographics, the mean age was about 74 years of age. They were about 1/3 female, and the STS was about 1.9%. When we presented this ACC, the astounding part is that demographics in both groups look very, very similar. As you notice, the syntax score, I missed that, but I do want to point it out again, is 2. So we really weren't treating people with coronary disease. We used general anesthesia in a little over half. I used general anesthesia most of mine because they were low risk and I wanted to get a TE and a perfect result. Everybody gets extubated, everybody goes to the recovery room. I don't think it makes any difference, although there are people that are pretty evangelical about this. We do about 80% of ours with conscious sedation, but in trials I tend to put them to sleep because I want a perfect result. Again, 99% transfemoral, 1/3 gets pre-balloon, 1/3 gets post-balloon. 1.2 had more than one valve used. And embolic protection devices became available for both these trials halfway through. We decided, and partner decided not to allow them. We couldn't ban them, but only 1.2% in this trial had an embolic protection device. So if we look at our primary endpoint, the point estimate for surgery at 2 years was 6.7%. For TAVR, it's 5.3%. It gives you a posterior probability of greater than 0.999. So this was highly non-inferior. In fact, we did a number of sensitivity analyses, including a worst-case analysis, and it remained non-inferior in all circumstances. So it easily met its primary endpoint. If we move to some Kaplan-Meier one-year statistics, sometimes that's easier to see. Our all-cause mortality disabling stroke, it was numerically less for TAVR, but no statistical difference. But again, I'm going to point out in every one of these curves, most advantage of TAVR in both these trials is in the first month. It's a safety marker for the first month. If you look at our hierarchical secondary endpoints, every single one of them were met for non-inferiority and superiority for flows, superior to everything, and superiority for KCCQ at 1 month. Again, this is what's matched every one of the randomized trials we've done. If we look at our composite, the composite safety endpoint was superior for TAVR, along with the individual parts of disabling stroke, life-threatening or disabling bleeding, and acute kidney injury. Atrial fibrillation and all-cause mortality or disabling stroke at 30 days was also superior for TAVR, whereas surgery had less pacemakers statistically. We go to 1 year, disabling stroke and heart failure hospitalization is still statistically in favor of TAVR. All-cause mortality at 1 year, notice 1.2% and 0.4% at 30 days. Big advantage at 30 days for TAVR. By 1 year, it's still numerically less, but no statistical difference. The surgical arm had a very good outcome. They had an ODE ratio of 0.63, so the surgeons did a great job in this trial. If you go to disabling stroke, you can see that at 1 year, it's 0.7 and 2.3 for a log rank of 0.024, so in favor of TAVR. Heart failure, 3.1 versus 6.4, log rank of 0.006 in favor of TAVR. And if you look at the procedural length, it's say much less for TAVR, which is what we expect with TAVR. It takes less time to do a TAVR than surgery. And the length of stay is less. If we look at our hemodynamics, this is one thing we've learned to expect from this supraannular valve, single-digit mean gradients and EOAs that are 2 or above. 2 or above. If you look at patient prosthetic mismatch, at 1 year, if you were assigned to surgery versus TAVR in this trial, your chance of moderate to severe patient prosthetic mismatch was 5.5 times that of the TAVR group. If you look at regurgitation, surgery does win this. The amount of regurgitation we see is going down. I will point out that we still had some first-generation valves, and we had few third-generation valves. So we were improving our valves as we went through this. Again, this is still an area where we need to improve, but it's getting better every year. Functional class, both these relieve aortic stenosis, so not surprisingly, both people get better. KCCQ, we've seen this in every trial, and these are almost all transfemoral. Transfemoral TAVR gets better much faster by 6 months. TAVR catches up to surgery, and it's the same at 1 year. If we look at a forest plot, we see the forest plot tends to favor TAVR in all areas, although there's no real statistical interaction. So my summary when I presented this was that TAVR with self-expanding valve was non-inferior surgery in patients with severe aortic stenosis at low surgical risk. TAVR showed better safety and recovery profile than surgery with less deaths or disabling stroke, shorter length of stay, better quality of life early on than surgery, but surgery had fewer pacemakers and less residual aortic regurgitation at 30 days. At 1 year, both groups had excellent survival. TAVR showed fewer disabling strokes and heart failure hospitalizations, and superior hemodynamics manifest by lower gradients or larger EOAs. And TAVR may be the preferred strategy in surgery with severe aortic stenosis and low surgical mortality in patient groups such as those that we tested. Now, the other thing is we did not use a composite endpoint, but if we took a composite endpoint that includes all-cause mortality, disabling stroke, or rehospitalization, what we find is this would favor TAVR also. So again, we had 2 trials that if used this type of similar endpoint, both look like they favor TAVR. It's one of the reasons that Gene Brunwald at this meeting said this was really quite an historic event. This paper was published in New England Journal, and interestingly enough, the day before the talk. It's another story for another time, but it is out in print if you want to read it. So thank you very much.
So we have actually a few minutes for questions.
Okay. Okay. Stun the room into silence. In some ways, it's unfair because Gilbert hadn't presented P3 yet, and contrasting those trials is actually very interesting. I think Nick is going to give us a good view on what the low-risk trials really tell us later, kind of from a statistician standpoint. The one thing I'll say to the surgeons in the group is that learn the data. You know, don't just read the high level, low risk. Learn the data. Bicuspids were excluded. That's a knowledge gap. We didn't do anybody with coronary disease. That's a knowledge gap. In P3, Gilbert will tell you 34% of the people were excluded at the national level. Why? We don't know because they're out of the trial, so we don't have any right to look at it. But a lot of them were probably because they had anatomy that wasn't favorable for TAVR. So we're not treating everybody that's out there. So as surgeons, I think it's very important for you to learn the data in these trials because you need to be able to converse with your patients and your cardiologist in a really in a granular manner. So
Mike, if I can just ask you something quick. Now that you know the data and you've been very much involved on the trial and you have done a fair amount of these cases, if you have to do this again and just redesign the trial and maybe increase take out some of the exclusion criteria or make some modifications, what you could have done different?
Well, one thing that I would have done differently if I could redo this. Well, first of all, I told Marty Leon I've always known he's smarter than me. Now I know he's better at picking endpoints than me if you want your trial just to win. And he's better at picking patients than me because if you look at the 1-year mortality in PARTNER 3, it's lower because they chose a lower risk group of folks. But what I do is the patients that got excluded from the trial at the national level, I would write into the protocol that those people are going to stay in the trial and we're going to follow them in a registry to see what happens to them. My biggest regret is we don't know what happened to those people. And we're never going to know what happened to those people because of the way we designed the trial. That's what I'd change. Yes, sir.
Bill, first.
Yeah. Bill Northrup, Atlanta. Michael, what do you think?
Do you mean to identify yourself?
Pardon me?
You did? Okay. And just I couldn't hear it.
Yeah.
Hello?
No, we're okay.
Okay.
Oh, okay, good.
Yeah, just...
No, in both of the low-risk trials, there was a lot of mild aortic regurg in the 30% range. What do we know about the impact of that over many years? Because certainly as surgeons, we would never accept that much, even mild aortic. We know that severe is really bad, but I don't know how much we know about the impact of mild. What do you think about that?
I think that's very worrisome. Vinod Thorani sitting out here. Vino presented the 5-year data of PARTNER 2A, the intermediate risk. What Vinod showed is that the survival curves for surgery in TAVR crossed at about 3 years. And that may be due to the residual AR left with the second generation XT. We don't know for sure. But much like we see in Syntax and some other trials, if you follow it up long enough, things do start to change. So that's a very, very legitimate concern.
Keith.
Very nice summary, Mike. So I don't remember that I saw that in the New England paper, but your pacemaker rate overall in your study was about 15, 17%.
17.3%.
And I know, and I share the concern that you had 3 different valves, but could you maybe tell me what the new need for pacemaker was based on whether you've got first generation core valve, Evolut R, Evolut Pro?
No, I don't have them segmented out. You know, the core valve is only 3.1% key, so it would be meaningless numbers. What I can tell you is that I've looked at every site and number of cases they did versus pacemaker, and it comes down. So my leading implanter, Hemelgado, who did 69 TAVR cases, had a pacemaker rate of 1.9%. We were the 4th leader, where ours was 5.6%. What we know is pacemaker is heavily related to how deep you implant this valve, and so it's related to the implantation techniques. You know, I think, and we've done a little over 2,000 at my place. We're in the single digits, but it's the high single digits. For
Yeah, I just think it's important to understand that the pacemakers are a known problem going forward, and particularly in a younger, healthier patient.
Yeah.
Getting a pacemaker is far from a benign thing. So it'd be important to know what the actual pacemaker rate is in Evolut Pro, because that's what we're implanting.
Yeah, so in the Evolut Pro trial, it was, I think it was 11%, Keith, when they ran, but that was a very small trial, and that's really important. In Reprise 3 that Ted Feldman and I ran, we looked at pacemaker dependency at 6 months, and half of the ones that were put in there were no longer dependent. So we're looking at a lot of things like, you know, 3 months leadless right ventricular leads, small pacemakers that can be taken out if they're not needed. But nobody wants, if you don't need a pacemaker, you shouldn't have a pacemaker. That and mild, those are both real legitimate concerns.
Yes,
John
sir.
Cardone. John Cardone, Fredericksburg, Virginia. Just building off the pacemaker issue, how do you handle your temporary pacemakers on these patients? I mean, 17% is a real number. You're going to see people with heart blocks showing up. You send them to the recovery room. Do you keep a temporary wire in? And since this isn't a self-expanding valve and it's going to continue to press on the conduction system, how long?
Well, it presses forever, but we don't see pacemakers to any extent after 2 days, as long as your QRS is less than 150 milliseconds. So we put them all into the neck with a temporary passive fixation lead. If you have a normal QRS going in and normal going out, and we haven't blocked during the case, we just pull it out. If you develop a bundle branch block, which is 35% of the people, we leave it in overnight and we test it. They come around by 9. They have to test every pacer that's in the blast, and my whole team. If it's less than 1% and your underlying EKG is okay, we take it out. If you're less than 1% and you still have a pretty wide QRS and it looks like it's over 150, we'll often wait another day. If it doesn't come down, we'll get our EP guys to see them. We don't do it right away, though. But we do. If you narrow in, narrow out, we just take it out.
Thank you.
Dr. Accola?
Oh, yeah. Frank Selke from Providence. The other concern is how long these valves last. You know, we should be coming up on 10-year data on some of these trials, so we should have the answer.
Yeah, so Frank, we are coming up with 10-year data, but they're all 84-year-olds. So, you know.
But in the low-risk patients,
Yeah,
the average age is 74.
eventually
I agree with the high-risk patients.
Yeah, we'll eventually have 10-year data on low risk. So the people that we have 10-year data on are all elderly patients that we wouldn't expect to fail anyway. So we don't really know the 10-year data yet, and you have to tell your patients that what we've done is tracking surgery, but they're older patients that we'd expect. You don't expect 80-year-olds to fail at year 5 or 6. You expect them to fail at year 8, 9, or 10. Now, the other thing I tell my fellow surgeons is that we sometimes fool ourselves about our own data, and every new valve that comes out, the surgeons want to put it in, and they say it's going to last like every other surgical valve. Those of us who have been around a long time understand that's not true. New valves are new valves. But we don't know, and that's why we're following them for 10 years. The intermediate risk trials have both been moved to 10 years also.
Kevin, one last question.
Yeah, Kevin Ackler, Orlando. Mike, thank you, and we owe you a debt of gratitude as well for insisting that surgical input has been a significant aspect of this entire process, so thank you for taking a lead role. The question I have is, unfortunately, low risk, some people equate that with young age, and inevitably on clinic days you spend more time telling someone why that they shouldn't have a TAVR as opposed to the people that you do. A 62-year-old that comes in, they've been told that TAVR's perfect for them. One, how do you go about that in your practice? We go through all the risks, and as Frank just alluded to, we don't know how long the valve is going to last. But also, as a follow-up, have you had any secondary coronary interventions after these valves have been placed? Because, you know, we see that as a potential problem too, particularly if we do open the gates and start putting them in younger people.
So 2 questions, Kevin. First of all, it's again, you need to understand the data so you can tell your patients whether they are part of the population tested. So how many people in Partner 3 were less than 65? Anybody want to guess?
None.
No, they were 7%. They got snuck in.
okay.
In Evolut, it was less than 6%. And less than 60 in Evolut, 1.3%. So the patient that comes to you, and I can tell you, having screened every one of those patients, if you were that young, there was something else going on with you. You weren't riding the MS-150.
Yeah.
You know, you were something else going on. So we did not test enough people below 65 to know. Coronary interventions, it's been surprisingly low that we've had to do that. At our site, we've had to do it multiple times. And what I find, Kevin, is we can get into the left pretty much ubiquitously. We can get into the right about 92% of the time. But you know, if you talk to a cardiologist, say, how often can you get in after a surgical aortic valve? It's 100% of the time. So that's still an area that, still a knowledge gap, an area that needs to be fixed. There are newer valves coming out that we're going to learn to orthotopically orient. Once we do that, it'll get better.
Great, thank you again.
Okay, so we're exactly on time. So the next one is Dr. Gilbert Tang. He's really like a leader on this field, and he's going to talk to us about balloon expandable valve in low-risk patients, results of the PARTNER 3 trial.
Thanks very much. Since Mike already answered all the questions, I will not have any questions, but it's truly an honor to follow Mike's footsteps to present PARTNER 3. I do have some disclosures. Number one, I'm an interventional surgeon. Second, I was not part of PARTNER 3, but my hospital site was part of Evolut Low Risk. And this presentation is actually a compilation of data already presented by Dr. Leon and Dr. Raj Makkar at previous meetings. So you can see PARTNER trial has really evolved from the first generation SAPIEN valve from PARTNER 1 to now PARTNER 3. You can see over 9,000 implants now across 3 generations of valve in multiple registries. Here's the PARTNER 3 trial design. You can see here symptomatic severe AS, STS less than 4, 1-to-1 randomization between the SAPIEN 3 valve and surgery with a CT substudy. The primary endpoint composite of all-cause mortality, stroke, and rehospitalization at 1 year. Moreover, there are number of separate registries. On the left side, there's a bicuspid registry. On the right side, there's also a valve-in-valve registry. But what I'm presenting here is 1,000 patients, including the CT substudy. Here's the inclusion criteria, again, very similar to the other low-risk trial, symptomatic severe AS or asymptomatic with a reduced ejection fraction. There'll be low surgical risk deemed by the heart team and adjudicated by a case review board. Here are some of the exclusion criteria. Again, bicuspid valve based on CT imaging is excluded, or severe calcification of the aortovalvular complex, and also complex coronary disease with syntax over 32, or adverse coronary takeoff with high risk of obstruction. Here's some of the clinical key exclusion criteria, which are common in most clinical trials. Here's the study flow, 1,500 patients with symptomatic severe AS between 2016 and 17 across 71 US, Canada, Japan, and New Zealand sites were considered being screened. About 520 of them were excluded, 300 of them due to anatomy, and at the end, 1,000 patients and 71 sites were randomized equally 1-to-1. Demographics were similar between TAVR and surgery. You can see here across all age, STS score, very low, less than 2% on the mean, and all the major comorbidities. You can see here in terms of the distribution between STS score on the left side for TAVR, the right side for surgery here, and also age group were quite similarly matched. So there are no major differences. In terms of in procedural results and hospital findings, you can see here, again, the main thing is that TAVR obviously has a lower length of stay, more patients discharged home, and fewer concomitant procedures. There are about 26% of patients in surgery undergoing concomitant procedures. In terms of valve size distribution, you can see here now across on the TAVR side, initially PARTNER 2, PARTNER 2 S3I, and now PARTNER 3, pretty similar in terms of anatomy distribution. For surgery, however, in PARTNER 3, the surgeons have now implanted larger surgical valves compared to the PARTNER 2A here previously. In hospital, in terms of complications, you can see here both the TAVR and surgery cohort are extremely low, less than 1% in hospital mortality, much lower than the STS PROM. And you can see here really no major complications noted in either arm. Primary endpoint, you can see here, this is a non-hierarchical composite, all-cause mortality, strokes, and rehospitalization in 1 year. This was performed as a non-inferiority followed by superiority. The cohort was analyzed as treated population, and sensitivity analysis were performed. And you can see this is the stroke definition per VARC2 criteria, and also you can see rehospitalization definition, similar to MVARC. Now, the reason for doing this is that there was expected lower event rates of death and disabling stroke in low-risk cohort, requiring a sample size of 1,000 patients, compared to enrollment times, and using just conventional statistics. And you can see here 1-year endpoint was selected for that reason because of prior trials. So here's the endpoint at 1 year, pre-specified non-inferiority margin of 6%. You can see here non-inferiority met and was demonstrated in terms of this composite endpoint, TAVR was superior to surgery. Here's the primary endpoint. At 1 year, 15% event rate between death, stroke, and rehospitalization versus in TAVR, 8.5%. And this was statistically significant and was superior as well. If you look at the landmark analysis, you can see most of the separation occurred in the first 30 days, and after that, essentially stays parallel. And here is again, in terms of component, if you stack them up, majority of them, you can see here the differences between all-cause mortality, stroke, and rehospitalization was statistically higher as we go along with surgery. All-cause mortality, you can see here, is really no difference. However, you look at the landmark analysis, again, also no difference. Here are the causes of death for the TAVR arm. There were 5 deaths only. No one annual rupture, pelvic perforation. This is not procedure related. There was 1 for hemorrhagic stroke and 1 arrest. And this is the surgical deaths. You can see here a couple of arrests, sepsis, ECMO, stroke, and other causes. In terms of stroke or stroke, here you can see again statistically significant between TAVR and surgery. However, if you look at the difference in the landmark analysis, most of them occur within the first 30 days as well. Rehospitalization, the same thing, with statistically significant favoring TAVR. And again, if you look at the landmark analysis, again, it all happened within the first 30 days. Here's some of the rehospitalization events. Again, it could be late pacemaker, sepsis, renal failure, recurrent AF, pleural effusion, pericardial effusion, and GI bleed. Here are the secondary endpoints. You can see here, from a bleeding standpoint, surgery is more invasive, so clearly there's a difference in terms of higher degree of life-threatening major bleed, as defined by VARC2. Vascular complications is very similar between the two, very low vascular complication rate in TAVR at 1 year. Again, CKD is pretty much at 0.45. Pacemaker rate was similar between the two groups at 1 year. However, there were more patients with TAVR with new left bundle branch block at 1 year compared to surgery. Hemodynamics were excellent between both surgery and TAVR. You can see here there was statistical difference, but you can see numerically it's really no difference, and I'm not sure what the clinical implication of this is. And same as for valve area, there was statistically a little bit higher AVA for surgery, but again, this is really just 1 point difference. In terms of paravalvular leak, you can see with the latest generation SAPIEN 3 valve, there's very little moderate PVL. There was around 28 to 29% of mild PVL versus 2% with surgery at 1 year. They also presented the CT sub-study at TCT last year. You can see here they also performed a CTs, about 168 patients on TAVR side and on about 144 patients on surgery side. And very interestingly, if you look at the incidence of HALT or hypoattenuation leaflet thickening, you can see at 30 days around 13% for TAVR versus 5% in surgery, which is higher for TAVR. But however, at 1 year, it's actually higher for both, with around 27% in TAVR versus 20% in surgery have leaflet thickening. Interestingly, if you look at what happened to these patients between 30 days and 1 year, you can see that some of the patients with leaflet thickening disappear in the TAVR arm, but also there were some that appear at 1 year. And similar to the surgical arm, you can see here some of them had HALT, disappeared, and some of them without HALT appeared. So we still don't know what the clinical implication of this is. Hemodynamically, though, there were statistically no differences whether you have HALT or no HALT among this cohort. There are some study limitations, as in any clinical trial. You can see there's only 1 year outcomes. As Mike mentioned, there will be follow-up to 10 years, including echo follow-up. And this is the result applied only to the treated population. Remember, bicuspid valve, non-suitable for alternative access or complex CAD anatomies were excluded. And so in conclusion, in this particular PARTNER 3 trial, compared to surgery, significantly reduced the primary endpoint of stroke, death, or rehospitalization by 46% at 1 year. All the composite primary endpoint and the components favored TAVR at 30 days and 1 year. And the secondary endpoints were also favorable in terms of hospitalization, KCCQ, and also there were less bleeding of TAVR and no difference in new pacemakers, vascular complication, obstruction, or moderate severe PVL. There were some secondary endpoints favoring surgery, however, including new left bundle branch block or mild PVL and gradients. TAVR had more rapid post-procedure improvement, no surprise, in terms of NYHA class 4, KCCQ and 6-minute walk test. And so really the choice of TAVR and surgery really should be a heart team decision, as we should be following. There are some knowledge gaps, as Mike mentioned, younger patients or other clinical factors that may benefit from concomitant surgery. So I think this slide summarizes very well in terms of surgery better, in terms of bundle branch block, mild PVL, and gradients. Surgery equal to TAVR of pacemakers, vascular complication, moderate severe PVL, and coronary obstruction. And TAVR was better in other indices, including the primary endpoints of mortality, stroke, and rehospitalization. Thank you.
Our next speaker is Dr. Vinod Thurani. We'll be discussing 5-year outcomes for Partner 2, implications for SAVR versus TAVR.
Great, thank you so much. All right, so these are my disclosures. So kind of in a similar pathway, what Partner 2A was able to do, just to remind everybody, Partner 3, which you've just heard in low-risk trials for low-risk patients, Partner 2 was in, Partner 2A specifically were in intermediate-risk patients, mainly between the STS scores of 4 and 8. And what we originally presented was a data in 2016 of this entire trial, and this was at surgery at versus TAVR at 2 years. There's really very little, almost no 5-year adjudicated true echo performed data, and that's what this study was the first to do. It compared the key clinical outcomes, the valve function, quality of life at 5 years for the first time in the largest trial done so far in TAVR. Mind you, it did use the balloon expandable XT valve, which did not have the sealing skirt as the SAPIEN 3 valve does. And again, to remind you what this looked like, we randomized 2,000 patients. First, we decided were they TF or TA, and when they went into TF, then we did a randomization between TF and surgical, so it's 775 in each group. If they had bad PVD, we put them into transapical or transaortic arm, and then they were randomized at that point against surgery, and you can see what the groups are. The primary endpoint was all-cause mortality or disabling stroke at 2 years for this trial. And again, just the generations of different valves, the SAPIEN valve, the original Partner 1 study, the SAPIEN XT, this is the Partner 2 study that we'll be talking about today, and then the SAPIEN 3, which you just heard about. Just again, to remind everybody, this was a 16 to 20% sheath, and also the first implant for the larger 29 valve was done in 2012, so more than halfway through the analysis. The other thing I wanted to point out is a lot of times when we started this study, we actually based things on echo, not on CT. So we were learning as we were doing this trial. We've talked about the primary endpoint, and I'll just skip through some of this to get you into some of the flow chart. So here you can see the TAVR patients. I think it's important to understand what happened in the first 2 years, both on the TAVR and the surgery side. So 160 patients died. Here's an important aspect that I want to draw your attention to. 43 patients from the 1,000 patients withdrew in the TAVR arm. 122 in the surgery arm withdrew, and the loss to follow-up was similar. This is a big distinction that I would just want to point out to you. And from years 2 to 5, you can see that the dropout was actually very similar. The patients who died were 200 and 269. The patients who withdrew were only 40 and 41. And loss of follow-up were more in the surgery arm, but overall, they didn't withdraw. They were just lost. So at the end of the day, there was a 91% complete 5-year follow-up in the TAVR arm, and there's an 81% in the surgery arm. And this is one of the limitations, I think, for the trial. So if we go back and remember what the demographics were, this is not the 73 age population. This is the 81, low 80s population. The STS score is right in the middle of 4 to 8, and it's about 5.8%. This is before the new calculations occurred. So today, this would be a higher risk patient population, but at that time when we did the study, it was an intermediate risk population. So these are the primary endpoints at 2 years and then at 5 years. You can see death or disabling stroke occurred. It was not different in 2 years, and if you look at 5 years, there's no difference. 43% in the surgery arm and 48% in the TAVR arm with no difference. And if you look and break it out, you can see all-cause mortality was similar at 2 years. It's similar at 5 years. Cardiovascular death, similar at 2 years, similar at 5 years. And you can see amount of strokes also similar, as are the 5-year follow-up. The strokes are similar. Let's look at this in KM curves now. Here you can see this is death or disabling stroke, so the entire primary endpoint. And here you can see for surgery at 5 years, it's a 43%. And quite honestly, this is probably the most robust data we've ever had, adjudicated data in surgery that we've ever done so far. And here you can see what TAVR is. When we put the entire primary endpoint together for the ITT population, you can see there's no difference between the two. I do want to show you the breakout. So at 2 years, this is what we looked at, 21% versus 19%. You do see, and Mike alluded to this earlier, if you start the clock over at 2 years, you can see when you go for the last 3 years, there's potentially a separation at 3 years, but this is not found to be statistically significant. Let's break them down now. Everybody says we do primary endpoints. Maybe we're clouding it. Maybe we're bringing in patients or ideas that don't make sense. So I'm going to break it down for you. This is just the all-cause mortality. It is not significant between the two populations. So 42% versus 46%. It's not significant if you just look at mortality. If you look at the primary endpoint, remember about almost a third of patients are transapical or transaortic. They do much worse. And I want to point out to you that the PARTNER 3 study and the low risk that you just heard, all of those patients were transfemoral for the most part. So the problem with PARTNER 2A is that we mixed in transthoracic and we mixed in transfemoral because that's what we thought we were doing at the time. So if we just look at the transfemoral cohort and take out the TA and the TAO, we know die faster, this is what the graphs look like. A p-value is 0.8 and they're on top of each other, both curves. There is potentially some separation or mixing around year 3, but at 5 years that shows no difference. And if you look at the primary endpoint for just transfemoral, you can see that transfemoral does better over the first 2 years, and then surgery starts to do better from year 3 to 5. And again, all-cause death in the transfemoral arm is really no different between the two. If you look at transthoracic, this is a problem. You can see that transthoracic TAVR by TA or TAO separates at 6 months, and it continues over 5 years to do worse. So that's why really, for the most part, TA, TAO have disappeared from the armamentarium of TAVR. When you look at this at a 2-year endpoint or a 2-year landmark analysis, you can see that TAVR was doing worse at 2 years, and it really separates out from year 3 to 5, really making a big difference in mortality for those patients. And if you look at all-cause mortality for transthoracic, you're seeing a much higher absolute numbers, and this is significant for surgery versus TAVR. In other clinical endpoints, I'll really point out to you just those things that are positive at 5 years. You can see that there are more hospitalizations in the TAVR arm. There are rehospitalizations. There is a higher AFib rate with the surgery arm, and you can see that there's more aortic valve reintervention in the TAVR arm, and I'll show you some details of that. In rehospitalization, you can see in the ITT population, starts to separate at around 2.5 years, where you start to see more TAVRs having rehospitalization. When you look at the reintervention rate, this is the TAVR group, 21 patients versus surgery, 5 patients. The reasons for reintervention, you can see the patients who had stenosis or regurgitation in the TAVR arm, but in the surgery arm, we had more endocarditis. When you intervened on these patients, you see that repeat TAVR was done in the majority of cases, 80% of patients. Some had valvuloplasty, some of them had surgery. For the surgical patients, the patients who had some type of need for reintervention, all of them had repeat surgery. It is quite interesting to me that when you have to reintervene on these patients, we had a 60% mortality, pretty high. In hospital, 60% mortality. When you have to reintervene on the TAVR arm, we had a 5% mortality. So the freedom from aortic valve reintervention using the surgical guidelines, not the echo guidelines, is relatively similar between the two. This is significant, but clinically insignificant. The valve areas, this is, remember, with the XT valve, not with the SAPIEN 3 valve. You can see that TAVR did better than did surgery. Just also remember that from PARTNER 2 to PARTNER 3, there was a big difference. We did a lot more root enlargements and did put in bigger valves than we did in the PARTNER 3 study than we did in the PARTNER 2 study, and I think that's a reflection of that. The mean aortic valve gradient, you can see, is on top of each other. So when someone asked the question, I think it was Frank, about valve durability, what we're seeing up to 5 years with the SAPIEN XT valve, we would think the same for the SAPIEN 3 valve. We're seeing no difference between surgery and TAVR valves in aortic valve areas or mean gradient. So we think that structural valve deterioration is not a problem up to 5 years in an 80-year-old cohort, and I think that's important. TAVR paravalvular regurgitation, somebody asked about mild regurgitation. You can see at 5 years, the amount of moderate severe was 6.5%, mild was 27%, and you can see here what it was for surgery. We still outperform TAVR in that regard. What does this mean? Does this mean anything? What this really shows you is that there is no difference in mild versus non-traces, p-value of 0.07. Those patients who have none to trace are in blue. This is just the TAVR population. Those that have mild have a slightly increased mortality, separating around year 3. But if you leave somebody with a moderate severe valve, they are going to die, and they're going to die really bad, such that almost all of them are dead at 5 years, and I think that's important. It doesn't matter if it's a core valve or a SAPIEN, leave them with moderate severe, and more than 2/3 will be dead at 5 years. So we did look at the non-trace. You can see that, that there's no major difference. If you have somebody who had a non-trace, that means you did a great job during the procedure. They do great at the first 2 years. They do great at years 3 to 5. KCCQ is improved for both. So as we kind of finish the thought of this, the study limitations, a couple of things. The XT valve is no longer commercially available in the United States. We have to be mindful of that, even though we need to keep looking. We don't want to be like where we just bring a new device in and we never look at the long term for the other stuff. So it's important for us to look at older generations. SAPIEN 3 is a lower profile, only 5% had transthoracic versus 30%, and much lower rates of PVR. We had less than 1% versus the 8%. Current findings at 5 years mandate re-examination at later time periods, and we're doing that. And we're missing some 5-year data, which I think is important, especially in the surgery patients. So in conclusion, at 5 years, we've shown that in an intermediate risk population, the primary endpoint in the overall population and the transfemoral cohort were similar for TAVR and SAVR. In the transthoracic cohort, the primary endpoint was significantly increased after TAVR. Valve-related rehospitalizations and reinterventions were, especially after 2 years, more frequent in TAVR. And of note is that the treatment for reinterventions was more well tolerated in the TAVR group. There's a small but significant difference in valve hemodynamics favoring TAVR. TAVR was associated with increased mild, moderate, and severe PVR. And in TAVR patients, the moderate severe PVR, but not the mild PVR, were associated with increased late mortality. And lastly, the TAVR and surgery results in improved cardiac symptoms at 5 years. Thank you very much.
So the next talk is by Toby Rogers from Washington Hospital Center. He's going to talk to us about TAVR in low-risk surgical patients, good enough for our siblings.
Well, thank you for the invitation. I am an interventional cardiologist, so I'm a little outnumbered in the room, I imagine. And I've been asked a very, very loaded question, but I'll do my best to answer it in as balanced a way as possible. So the prior speakers have done much of my work for me. They've really summarized beautifully the results of the low-risk trials. And we have sort of 4 trials that we can draw upon, of course, the 2 pivotal studies being the most recent and the most relevant. And it's important to recognize both of those studies really broke through just the medical literature, and this was the headline of the New York Times to the time of ACT last year. And so I suspect that most of you in this room have had young, low-risk patients come to you asking for TAVR. And certainly that's the case for me in my practice. And so we have to ask ourselves, how do we address their concerns and their questions, and how do we give them a balanced answer when they're asking for one particular therapy based on what they've read in the newspapers? So we have to go back to the beginning and ask ourselves, who were these low-risk patients? And some of the prior speakers have already emphasized this. But these low-risk patients, and these are the 3 US studies in low-risk patients, were in their low 70s. They all had transfemoral TAVR, and none of them were bicuspid. So we cannot generalize or extrapolate the results of the low-risk study to the 55-year-old bicuspid patient with peripheral vascular disease. And that's a starting point. It tells you which patients, just off the get-go, we have to be careful how we counsel them. We will get a little bit of bicuspid data in the next couple of months, both from LRT and from a couple of the other studies. What we can tell our patients, though, is that certainly mortality with TAVR is very low in these low-risk studies. And again, look how far we've come from the early studies in extreme and high-risk patients all the way down to low risk. We can also, this is a very busy slide and I won't go through it all, but we can also tell our patients that, at least in the low-risk studies, those two variables that were always considered the Achilles heel of TAVR, that is PVL and pacemaker, have really come down to the point that, at least in the PARTNER study, look at that, pretty much no difference between surgery and pacemaker for moderate severe PVL and for pacemaker between surgery and TAVR. But what matters more to many of the patients that I see who are a younger age and are still working is actually that recovery. And so the benefit of TAVR in terms of rapid recovery, rapid improvement in KCCQ, rapid recovery in NYHA and 6-minute walk really matters to these patients much more than some of the other things that we maybe perseverate about in clinical trials. Now, it's important to note that the surgery catches up, but if getting back to work after your procedure is important to you, then these things matter. So what, to me as an interventional cardiologist, are still the outstanding issues? Well, durability and structural valve deterioration clearly is an important issue, and we'll talk a little bit about that. Hemodynamics often goes hand in hand with that. Bicuspid patients, still an open question. Coronary access, and then TAVR and TAVR. So let's go through a few of these. I'll start with bicuspid. We don't have any data. Watch this space. I think that's what you have to tell the patients right now. We just don't have data. So let's talk about coronary access, and we had a question about this earlier. This is a very nice review paper published a couple of years ago, and it just highlights that when you think about coronary access after TAVR, you have to factor in anatomical factors, that is the shape of the patient's root, but also the design of the transcatheter valve that has been implanted. So these are two patients from our low-risk TAVR study, and I think you can all imagine if you're a coronary operator, you'd much rather be dealing with that patient on the left with the valve that sits well below the coronaries and you can get in easily than the patient on the right whose transcatheter valve sits well above the coronaries, and you're going to have to engage through the cells of the TAVR valve in order to perform your PCI. And so, again, we'd much rather be engaging over the top, but that's just not always the case. We also have to factor in the fact that we don't have control of where the commissures land in the same way that you do in the operating room. And so this patient here has a commissural suture post sitting smack bang in front of the left main, and that is clearly going to interfere with how we engage. It doesn't mean we can't do it, but it's definitely going to make it more difficult. And when you're dealing with a STEMI in the middle of the night, these things give interventional cardiologists pause for thought. We analyzed our low-risk data study. Every patient had a CT at 30 days, and we found that at least 50% of patients who had a balloon expandable SAPIEN valve, the frame of the valve sat above the coronaries. So in 50% of patients, you're going to have to engage through the coronaries. And in approximately 1 in 12 patients, or 8% of patients, not only is the frame above the coronaries, but there's a commissural suture post smack bang in front of it as well. So again, just because this is a low-profile valve doesn't mean it's going to be guaranteed access to the coronaries. And of course, the higher-profile Evolut valve, by design, sits above the coronaries in 100% of patients, and you're always going to have to engage coronaries through this. And the same concerns of rotation, orientation, or position of the commissural suture post stands. So this is something that we have to think about if we're going to put valves in younger patients with pre-existing coronary disease. Even if it doesn't need treating at the time of TAVR, how are we going to deal with the coronary disease progression in the future? In terms of hemodynamics, the truth is that in 80-year-olds, we haven't really paid that much attention to it because they don't do very much. But if we're going to offer TAVR to younger patients, then we have to think about offering them the largest effective orifice area we can because they actually want to be active and do stuff. That certainly gives me reason to think that maybe we should be choosing for them the valve that gives them the best hemodynamics. And this is the data from the Evolut low-risk study showing superiority of TAVR hemodynamics over surgery out to 2 years. Subclinical leaflet thrombosis, we've already heard some of the data from the PARTNER. This is a phenomenon that was first identified with TAVR but has since been shown to affect every single bioprosthetic valve, be that transcatheter or surgical. And in our low-risk study, we found an incidence of hypoattenuated leaflet thickening of 14%, which is almost identical to that of the PARTNER study and just a little bit lower than the Evolut data. And at least in our data at 30 days, this did seem to have an impact on valve hemodynamics with worse hemodynamics in those patients who had leaflet thickening, although it didn't seem to be there at 1 year. So again, we have a lot of questions about this to answer going forwards. This leaflet thrombosis obviously factors into our thinking about structural valve deterioration. And if we use a definition based on hemodynamics, then at least from the NOTION study, which is a Nordic study of low-risk patients using the original CoreValve Classic, TAVR seems to do better in the long run in terms of structural valve deterioration compared with surgery. And this may be because of superior hemodynamics at baseline, less patient-prosthesis mismatch, but it does make me wonder as well about things like leaflet thickening and how that affects different types of valves differently. But then if we look at the PARTNER 2 data that Vino just showed, well, actually, the SAPIEN 3 seems to do very similar to surgery in terms of structural valve deterioration based on hemodynamics at 4 years, but there's a signal that the XT may not be so good, and that may be related to more PVL or just smaller valves and not such a good job in terms of sizing. This is a very interesting paper just trying to predict structural valve deterioration. These are obviously surgical valves using PET, showing increased tracer activity in the leaflets seem to correlate with higher gradients of development of structural valve deterioration down the line. So it may be that we're able to predict this, but we still have a lot of questions in understanding this phenomenon and how this is going to factor into our decision making. As an interventional cardiologist, I hear from a lot of surgeons, well, you don't have data on durability and we do. Well, actually, my personal read of the surgical literature is that this is very disparate. This is a systematic review from the Cleveland Clinic of 167 studies and 12 FDA reports, noting that there were 11 different definitions of structural valve deterioration were used across the surgical literature, and that the follow-up data, the length of follow-up for some of these valves range from as less than 1 year to 14 years. So to me, the data on durability of surgical valves is very, very difficult to pass. There's a lot of comparing apples to oranges. And the truth is the best data that we're going to receive for structural valve deterioration of surgical valves is going to come from the TAVR literature. So how do we manage lifetime? How are we going to manage the patients for lifetime? Well, do we do surgery first, then valve in valve? Do we do TAVR, then SAVR, then valve in valve? Do we do TAVR, then valve in valve, then SAVR, then valve in valve? There's a lot of questions here, and we don't have the answers, and I think this will be interesting for the discussion later today. But certainly putting a SAPIEN inside a SAPIEN turns the first valve into a covered tube, and potentially, as you see in the image on the right here, you could occlude a coronary artery. The same Evolut inside an Evolut turns the outer valve into a tube, and you may not be able to get into the coronaries if you implant a second valve inside, or you may in fact occlude or flow down the coronaries and cause coronary obstruction there on the table. At least looking at our low-risk data from the low-risk study with the SAPIEN valve, we found that roughly 1 in 8 patients probably can't have another valve because of risk of coronary obstruction, just because of the way the first valve sits in their anatomy. So again, lots of questions about lifetime management, and lots of the theories about being able to do TAVR and TAVR in the future may not stand. So just to come back and to finish up by answering that question I was asked, well, is TAVR good enough for my siblings? Well, I'm still young, and based on my read of the literature, no, my siblings should still have surgery, and they should have a mechanical valve. Is it good enough for my parents, who are in their late 60s, early 70s? Absolutely. I think the data is good enough. My parents should have TAVR, and they should have the choice of valve tailored to their anatomy. Thanks very much.
The next speaker is Nick Fremantle, and he will be discussing low-risk transcatheter aortic valve replacement. What do the latest data tell us?
Thanks very much. Good afternoon, everybody. It's a great pleasure to be here, and thanks to the SCS for the kind invitation to take part. These are my disclosures. That one? Yeah. I'd just like to stress that although in the past I've received funding from manufacturers of relevant devices, those are outside of the reporting period, and my organization receives money for a grant from EACTS to support a methodological support unit. So I'm the statistician, so I'm going to start off by asking, why do we do randomized trials? And Ronald Fisher, who I'm sure you all have heard of, the father figure of modern biostatistics and of modern randomized trials, said the simple act of randomization assures the internal validity of the test for significance. Well, what on earth does that mean? It means that randomized trials can provide us with unbiased estimates of treatment effect. But there's a caveat. They can only do that if you do them correctly. So let's have a look at the low-risk trials. The first point I would describe as catastrophic loss to follow-up in one-year outcome studies. We have nearly 7% loss to follow-up in both Evolute LRT and in Partner 3, with more than 10% in the surgical groups. When we are looking at a low-risk population with a low event rate, you can see that we're losing more patients than are experiencing many of the events in the trial, and that is a problem because we don't know what happened to the patients that are missing. I'm sure the investigators will tell us that the reason why the loss to follow-up in the so early on, before procedure, in the surgery groups was so high was because TAVI is so massively popular. Well, I'm afraid my answer is you managed to put to do surgery on around 90% of those patients who are randomized to the surgical groups. There's still an open question about these products and their use. And frankly, more work in the trials before randomization in the run-in period could have left us in the position where these trials didn't have that hole in the water. Those patients who weren't suitable to be randomized because they weren't going to have surgery, if they happened to be randomized to that group, those patients could have left the trial before randomization without causing this problem. The FDA used to be very tough on this, and I'm not quite sure what's happened, but anyway, something has changed. Perhaps consequently, the principal analysis of these studies is as treated, or sometimes called per protocol, and that is that the clock is started in the trial for the patient if and when the procedure is undertaken. This is well known to be biased where treatments are unblinded, and as ICH-E9, the statistical principle for clinical trials, which really focuses on, for reasons I've never understood, really on pharmaceutical trials and not on device trials, states very clearly, the bias, which may be severe, arises from the fact that adherence to the study protocol may be related to treatment and outcome. And as Dr. Reardon just commented in his presentation, not knowing what happened to all of those patients that went missing is going to dog us for many years to come. Is a major regret with these studies. Now, a personal bugbear of mine, concealment of allocation, that is whether we know which group or we have an inkling of which group the next patient's going to go into. Now, I know from being a trial statistician in many trials, through the correspondence that I have with sites, that at sites, you guys often count up how many patients you've got in one group or the other. And if you've got more in one group than the other, you think, we're more likely to have the next patient go into the group that's got fewer patients in. Now, in a simple randomization, that's not true. But if you're using some kind of a blocking structure or a minimization structure, it is. Partner 3 used a block size of 4. Evolute LRT used a variable block size between 2 and 6. It sort of amounts to the same thing, but the math's easier for partner 3. So what does a block mean? It means we don't randomize a single patient. We randomize the positions in a structure of 4, a cell of 4 patients. What might that look like? Well, here are the 4 patients. In our 4 patients, in our made-up Partner 3 trial, 2 of them will go into TAVA, 2 of them will go into SAVA. If the first patient goes into TAVA, then it's very easy to work out that you've got a 2 out of 3 chance of the next one going into SAVA. So it's more likely that the numbers will correct. If you have the one after going into TAVA, then it's deterministic. The next 2 will be SAVA patients. Obviously, the trials are really a little bit more complicated than that, but if you work it out, the probability of the next allocation being self-correcting, going back into a balance again, if a site has an imbalance of 1 subject, is 75% in Partner 3, and 100% if the imbalance is 2 subjects. And in Evolute LRT, it's nearly as bad. 71%, I think. Again, statistical principles for clinical trials, this is just problems. It is particularly important that the investigator's knowledge of the next treatment should not influence the decision to enter the subject. This decision should precede knowledge of randomized treatment. I know that at sites you try and guess what's going to happen next because you tell me you do. And we can see in these studies that there are high preferences amongst investigators for one against another treatment. That looks like a recipe for problems which we simply cannot measure the magnitude of. There's a few real gaming issues here. A non-inferiority boundary of 6% in an outcome study. Surely you're not going to argue that a difference in stroke and all-cause mortality of up to 6% is unimportant. I know Dr. Stone has made some comments along those lines recently, but I mean, this really is getting beyond it. As a middle-aged man who may end up with one of these procedures, 6% is not non-inferior to me. Evolute LRT had a non-inferiority boundary based on a one-sided 5% test. When I read that, I thought I was going back to the dark ages. The one-sided is right. We're only interested in one direction, but it should be 2.5%. Making it 5% takes the boundary up to 7%. Almost anything could pass that threshold. Studies correctly use hierarchical alpha spending plans to work out what goes onto the label, what can be considered proved. Both of these studies did this. It's good practice, it's not bad practice. I'm not criticizing it. But we have to get the criteria right, or else we just make it a free lunch. If we look at, here's Evolute LRT, if we look at the New York Heart Association class threshold for no difference, we see the mean is 0.375 New York Heart Association classes. Now, having worked on several heart failure trials, I know that is not a clinically unimportant difference. Similarly, the mean Kansas City cardiomyopathy questionnaire has a non-inferiority boundary of 5 points, when John Spertus and colleagues who developed the score said that the minimally important difference was 3. Almost anything is going to pass these thresholds, and we see by design, in a way, the gaming that's going on. The easiest point, it's come up already, follow-up in Evolute LRT is 12.2 months, and in Partner 3 it's reported out to 12 months. Is that long enough to make a decision? This is peri-procedural. For a younger population with a long life expectancy, this seems a very short time on which to be granting a marketing authorization. Differences between devices. Well, I am denied about whether to put this in, but it seemed interesting. So surprisingly little discussion, a little bit came up. It is obfuscated, particularly in the device field, by the regular device upgrades and occasional recalls. The world keeps on changing, and whenever there's a problem, the answer is, well, it's not like that with the new one, although we don't have any data for it yet. I've gone backwards there. Why am I going backwards? I'm still going backwards. Pressing the left-hand one. I tried the right one, I was still going backwards. I'm going forwards again now. Hey! You can take that off my time. Here we go. If we look at the pooled Medtronic TAVR devices, just from Certavi and Evolute, we see an odds ratio of nearly 4.2. That's highly statistically significant, way out on the right-hand side for new permanent pacemaker implantations compared with surgery. So 4 times the number for those devices. We've heard good news for the Edwards devices with an odds ratio here of only 1.2, but it's not all good news, because if you look at the width of that confidence interval, almost all of it is putting it on the side that benefits SAVR, and we've got still quite small numbers of cases. But these devices are different. There's a highly statistically significant interaction between the rate of new permanent pacemaker implantation risk between the devices. Why is this important? Well, we know only too well that patients who end up getting a new permanent pacemaker implantation do really quite badly out into the future. It's a very poor prognostic marker. So, some quick interpretation. As far as I see, the statistician's view, TAVR may or may not be a safe and effective alternative to surgery. And I don't think you can tell from these poorly designed trials. For me, the regulator is asleep at the wheel. Why are Class 3 devices judged on such different standards from pharmaceuticals? I don't know. I interact regularly with EMA and occasionally with FDA, but I must be meeting different people. I just don't know what's going on. We have very highly skilled sites doing the procedures. We often hear in the presentation of these studies about the effort that goes into making sure that things work, that the devices are delivered by experienced people in an effective way, people who know what they're doing. Now, of course, that's the right thing to do because we need to make sure that we're making a comparison of what's possible, and what would be possible in established practice. But can this be achieved in the rollout to actual practice? Will the results be the same in general use? And crucially, will they be the same in longer follow-up? Well, throughout my career, I have watched and benefited from methodological advice from the FDA from Dr. Temple, Bob Temple. I recalled when I was looking at these studies a workshop that I went to back in 2005, I think, with Dr. Temple, when we were looking at actually trials in interventional cardiology, one of which was mine, and he said of the trials, some of these trials are so flawed methodologically that they are at best thought of as observational studies. I'll point out that he wasn't including our trial in that, thankfully, but if we do look at the observational studies, what do we see? So this is one of the increasing number of propensity score-based, registry-based studies. I've been involved in some of these myself. We see a slight increase in all-cause mortality, but a real increase in all-cause mortality in the peri-procedural period in this study, and then we see a divergence in mortality out to 5 years. Now, of course, the investigators from the trials will tell us that these studies are biased, and yes, they're absolutely right, they're biased. But the problem is the trials that we're looking at are biased as well, and it's very difficult to work out what the truth is. So just to finish, comparative trials are always challenging. Sponsors and trialists always game the results. It's a sad truth. It's one of the reasons why regulators in pharmaceuticals like placebo-controlled trials, because you can't game a placebo. Nonetheless, it is frankly surprising to see quite how poor the design of these studies is, which are most definitely not in the patient's best interest. Thanks very much for listening.
That was an outstanding talk, and I was actually wondering if the audience was a little different, if the last two talks, how would have been perceived. So anyway, looking forward for the next one, Eyes Wide Shut, the unpublished data from partner 1A from Dr. Furnari.
Thanks, Rania. Ed, thanks for letting me be here. These are my disclosures. You know, we as surgeons accept the fact that there's truth in data and that science will prevail. We also accept the fact that TAVI's here to stay. The results have been better than we knew they would be or thought they would be in all risk populations, and it's radically changed our specialty. But we can't ignore, and we can't ignore the data, the science, and the outcomes. And they were first presented to us for Partner 1A, and these publications in 2011 and 2012. And these publications from the partner study, Partner 1A, told us that TAVR was non-inferior to SAVR through 3 years, and all mortality, symptoms, hemodynamics, and MACE. And this looked like a slam dunk when it was sent to the FDA. It was going to be a slam dunk. And it went 1 month later to the FDA, and it was approved. But it wasn't a slam dunk. It was approved by 1 vote, 5-4, and it could have gone either way. So what was it that the FDA and Edwards found out that we didn't know, that we've never found out? So we looked at all 21 documents that are available to us and all 1,200 pages that were produced by the FDA and Edwards, including the FDA executive summary. And we found that there are a bunch of unpublished data. And they implicate or indicate that clinicians and study investigators were not told the whole truth about the Partner 1A data. And this assured clinical acceptance and likely affected the future patient selection and outcomes. So using this and knowing that there's truth in data and that we can't ignore the data, the science, and the outcomes, I give you eyes wide shut, the hidden data from Partner 1A. Chapter 1, If I Only Had a Brain. Now, we all know that we were told that TAVI has the same rate of stroke over time that SAVR does, and they showed us this great graph with an x-axis of 70%. But when you look at the number of events that occur at every single point in time, there's a 2 times higher, highly significant difference between SAVI and TAVR. Now, this isn't completely unpublished because Craig Miller published it at the 1-year time point for transfemoral and shows it was actually 3 times higher in the TAVI stratum than in surgical. Chapter 2, If I Only Had a Heart. We again all know that there's more aortic insufficiency or PVL with TAVI than there's with AVR, but we were shown these sort of rainbow-colored graphs. It's hard to make a differentiation of how much there is, how much difference there is. So let me make it clear to you. There's 3 times more PVL with TAVI than there was with SAVR. And why is that important? We all know, again, whether it's total AR or it's paravalvular AI, that AI affects outcomes in the TAVI population. What we weren't told, and what's very important, is that AI had no effect on survival after surgical aortic valve replacement. No effect whatsoever. So either there was less AI than was reported in the surgical population, more AI than was reported in the TAVI population, or these are completely 2 different operations treating 2 completely different patient subsets. And it might be all 3, because what we also weren't told was that surgical aortic valve replacement has better reverse remodeling than TAVI. There was 84% better end diastolic volume reduction and 53% better LV mass regression with surgery than there was with TAVI. Again, never published, never told. Chapter 3, TAVI is not non-inferior to all SAVR. Think about that for a minute. TAVI is not non-inferior in all SAVR. Now, non-inferiority was determined by the lower 95% confidence interval of the difference in survival between the 2 therapies in the intent to treat group at 1 year. And if that lower confidence interval was more positive than minus 7.5%, it was non-inferior. If it was more negative, it was not non-inferior. So in the whole group, it was non-inferior. It met that criteria. However, what we were not told was that TAVI was found to be inferior to AVR in males. And the male population, which consisted of 400 patients, more than enough to determine significance, the lower confidence interval was minus 10.8. It did not reach non-inferiority. And the FDA was highly concerned about this. They mentioned it no less than 3 times in the executive summary. And I'll point out the bottom line here, non-inferiority was not met in the male stratum, and I did not underline that, and I did not put not in capitals, the FDA did. They implored Edwards to look into this further. It was never looked into further, it was never published further, until 2015 when a meta-analysis came out. And that meta-analysis of 11,000 TAVI patients showed that female sex was an independent predictor of late survival after TAVI. So they put a positive spin on it, but because that's a dichotomous variable, what that means is male sex is an independent predictor of early death after TAVI. That's the exact same statement with a positive spin. And what O'Connor says is this should be taken into account during patient selection for this procedure. We've never been told that for males, but we were told it's great for females. Chapter 4, shifty nomenclature hides the valve implant comparison. Well, the intent to treat group, and I really enjoyed Nick's talk, the intent to treat group was the randomized group, but it turns out that there was not a mutual intent to treat and be treated in that group. The as treated group, people who agreed to undergo the operation, doesn't mean they actually got the valve, it just means the procedure was begun. And as treated definitively does not mean the prescribed valve was implanted. And so there was no valve implant group comparison. ever done. But so let's look at this. In the TAVI population, there are 348 patients randomized to TAVI, and 344 underwent TAVI. Of those 344, 18 patients did not have an implant. And 11 of those 18 patients crossed over to surgery, but because the as-treated arm was treated as an intent-to-treat arm, they were left in that arm, and their data were reported with the as-treated arm. In those 11 surgery crossover patients, there was only one death for a 9% mortality. That 9% mortality served to improve the mortality in the reported as-treated TAVI arm. What about the surgical arm? There were 351 patients randomized to surgery. A full 38 patients, 11% of those patients, did not undergo surgery. They did not want to, they refused to do it, and so this was not a mutual intent to treat and be treated. 313 patients were in the as-treated arm. 2 of them actually had no implant, and 1 actually crossed over to TAVI, leaving us with 311 patients in the actual valve implant arm. In those 311 patients, there were 40 concomitant operations, and these weren't simple operations. These were AVR CABG, double valves, triple valves, AVR, root enlargement, ascending aortic replacements, aortic endarterectomies. These are big risk operations. And indeed, in those 40 patients that were included in the AT arm, there was a 42% mortality. This served to make higher the mortality in the supposed as-treated arm. So how do we get a valve implant comparison out of this? Well, let's start with the ITT arm, with the TAVI arm. If we remove the crossovers and remove the no implants, we're left with 326 TAVIs that actually got a TAVI. We take the one crossover from the surgical arm that leaves us and calculate the mortality at 1 year was 24.5%. Now we move to the surgical arm. In the surgical arm, we remove the 2 non-implants. And in order to do an apples-to-apples comparison, we want to compare isolated AVR to isolated TAVI. That's what everyone wants to know. This was not a study comparing TAVI to AVR CABG or TAVI to double valve, triple valve, or root replacements. So we take these patients out, and we're left with 271 isolated surgical aortic valve replacements. We add back in the 11 crossover patients from the TAVI arm, and their 1 death. And so the isolated surgical aortic valve mortality in the PARTNER 1A trial was 21.6%. Now we compare the 2 mortalities at 1 year. This shows a delta, or in 1 year survival, of minus 2.83%, with a 95% lower confidence interval of minus 8.43, which is more negative than minus 7.5. And so non-inferiority endpoint was not met with a p-value of 0.85 in the actual valve implant group, comparing apples to apples. In this group, SAVR was truly superior to TAVI. So in summary, high-risk TAVI is inferior to isolated SAVR in the valve implant group from PARTNER 1A. Was known to be inferior to SAVR in males since 2012 by the FDA and by Edwards, but we were never told. Had a 2 to 3 times higher stroke rate at all time points versus SAVR, and has significantly less reverse remodeling versus SAVR. And as a side note, surgical aortic valve replacement with aortic insufficiency does not affect SAVR survival. None of these were told to us in the 2 cornerstone publications in the New England Journal for PARTNER 1A or have ever been shown again from that trial. And so we can only conclude that the medical industrial complex, having invested billions of dollars into the development of TAVI, wanted to ensure regulatory and clinical approval, which would result in positive economic success and a positive return on their investment. And in that quest and to that end, they've withheld important clinical data, which has impaired the ability of the medical community at large to fully evaluate the comparative effectiveness of TAVI and its impact on specific patient populations. This has irreparably altered clinicians' ability to rationally and safely deploy this excellent technology to the appropriate patient populations without concomitantly unwillingly and unknowingly doing harm. The truth is out there. You deserve to know the truth. Patients deserve to know the truth. Cardiologists need to know the truth. And it's more than just the truth about data. It's the truth about how the study was put together and how the data were ethically or unethically not released. Thank you very much.
The next speaker is Dr. Joe Bavaria, who will be discussing the current global landscape of aortic valve intervention and requirements for future success.
Thank you. The room is packed. How do we move this along?
Slides to work, please.
There we go. I'm having the same problem that our statistician did. There we go. So the subtitle was, "What is required for future success?" Why is this?
Can we make the slides move forward, please?
The wheel? Oh, okay. All right. Okay, my disclosures. Regarding this talk, there's a couple of significant disclosures. I'm the TVT Steering Committee Chairman. I was the chair of the writing committee for the institutional operator NCD and some corporate ones, as well as a founder share and equity holder for TMVR, nothing to do with this. And also, this is very important, I love TAVR, and I do it all the time, and I really enjoy it. So, for the talk that was assigned to me, one thing is, what about the aortic valve universe, and where does it stand today? We could almost do this whole talk on this one slide. So TVT National Volumes and Data, snapshot of US practice patterns. Let's set the stage. So the first one is this is from the TVT database, what we're looking at is a dramatic increase in the United States from the TVT database, which is a nationally run database required by law. If you do not enter your data into the TVT database, you will not get paid. And so everybody does it. And it's audited at 10% per year of all sites. And what we see is a pretty good sized growth, and we'll see 75,000 TAVRs this year in 2019 in the United States. Interestingly, we have 642 sites. We're actually up close to 700 now. So it's pretty broad-based, and the access is reasonably decent. This is a slide I put together linking the STS national database, which is 92% of all surgical procedures in the United States on the cardiac side, as well as a TVT database, which is 97% of all TAVR procedures. And you can see a couple of really important things here. First of all, the TAVR numbers are going up like crazy, and we're going to see 75,000 in 2019. The rest of the lines are AVRs in various buckets with a total. The total is the blue line addition. And you can see this is root procedures. The green line is AVR cabbages. The yellow line is AVR others, which is AVR double valves, AVR with aortas, all the stuff that Dr. Fernie just published, just talked about on the 41 patients from the Edwards trial. And then this is isolated AVR, which is, as you can see, is down a little bit. So TAVR for the first time in 2019 surpassed all SAVR in all of its forms. SAVR surpassed isolated AVR in 2016. However, incredibly, Bentall procedures are up 15% annually for the last 5 years, and AVR other category is flat or is even slightly up, and AVR cabbage is slightly down. This is actually better than expected considering the revolution of TAVR that you see. So what about the TAVR revolution? I'm not going to go through. I'm going to go through these real quick because everybody's seen these a million times today. This is the low-risk trial. Excellent results. I'm not even going to talk about it. This is the same one. Excellent results in the low-risk trials. But the revolution additionally has some big data. So let's look at some real-world clinical outcomes. So on the good side, TAVR's done really well. This is from the National TVT database with 250,000 patients, 250,000 implants of a nationally required database. And first of all, we're going towards transfemoral. That's great, and things are good. In fact, it's even better than in Europe. Moving excellent for patients, moving towards TF. Look at in-hospital major and life-threatening bleeds. We know in this patient population this is a serious issue, and it's getting better and better. Complications continue to decrease. However, they have been a little bit flat for the past 3 years. TAVR mortality. TAVR mortality for in-hospital 30-day and 1-year mortality. The green is 1 year. The red is 30 days. The blue is in-hospital. Steadily improving national results. 30-day mortality is a little bit flat, but it's generally quite satisfactory from this real-world data set, this giant data set. TAVR disposition is excellent. The country is doing well. We're increasing our discharges to home and decreasing our discharges to rehabs and nursing homes. Excellent. Science tells us what we can do, guidelines tell us what we should do, and registries tell us what we're actually doing, which is an important point. So from the randomized critical trials and the TVT big data, TAVR is doing well and the trend will continue. And this has ended up being into the CMS, into our decision memo, the NCD regarding TAVR. So the NCD in 2019, after P3, opens up, and low risk, opens up to TAVR access, but maintains the heart team. The surgeon and interventional cardiologist operator teams are live and well by law. Institutional requirements are stated. TVT registry is mandated for equality, and it's highly suggested quality composites are being done in the United States of America. And there is a volume outcome relationship. This was a New England Journal of Medicine paper from the TVT registry showing approximately 27% risk reduction in high volume versus lowest volume centers. So the data, we're getting more and more data out there. Additionally, the TVT registry, at the behest and request of the CMS, is now coming out with a composite risk model for TAVR. And this risk model uses a global rank methodology where death is worst and none is best, and has stroke, bleeding, AKI, acute kidney injury, and paravalvular leak in the risk model. It'll be really an important concept, and it'll go live in 2021. So what about AVR or SAVR? How is the data? And we saw some of this already. The answer is it's probably a little better than you think. This was the recovery trial that just came out a couple of days ago at the American Heart Association, presented at the American Heart and New England Journal of Medicine. And what you see here is operative mortality or death from cardiovascular causes, and this is against regular surgery in very low-risk patients, very severe AS. These patients had velocities over 4.5. Even if they're all asymptomatic, this was really a very important trial. This data will get into the guidelines. But what's really interesting is the secondary thing. SAVR is great. This is actually the SAVR line of this prospective randomized trial, and the very first death was greater than 2 years out. I mean, this was unbelievable. But the STS scores and Euroscore 2s were 0.7 and 0.8 respectively. So these are very low-risk patients. Point being, SAVR in this group was incredible. I'm talking incredible. So how good are the new SAVR valves? Well, let's just look at some recent FDA trial data, which is the Trifecta and the COMMENCE trial. So here's the Trifecta trial, which was published in 2011 or 12 from a large FDA study. And these are seriously excellent gradients in this very large trial. This is another trial looking at the same Trifecta trial looking at PPM. Well, patient prosthesis mismatch was almost non-existent, less than 4%. This is severe. And remember, listen to the definitions. Definition, by the way, and this gets into some of the stuff that Dr. Fernuri was just talking about, the definition of PPM across the globe in the cardiac surgical and cardiology community is 0.65. There is no need for a definitional change here. And AI is basically non-existent with good surgery. So that's the Trifecta trial. Well, let's look at the COMMENCE trial. COMMENCE trial was also incredible. Most recent large FDA pivotal trial, 689 patients, average age was 67. All-cause stroke, 1.2. All strokes, 1.6. Paravalvular leaks, basically 0. Pacemakers, only 4.5%. And the mean gradient was 10 for the entire trial. And the BAB subgroup did better. And the gradients out to 4 years are also still 10. These are really nice data. More recent data from in 2018 regarding the Trifecta trial basically showed that in everything but a 19-millimeter valve, there was 0 severe PPM and only 20% moderate PPM in this large trial. So that's pretty important. The SAVR data is pretty good. Well, let's look at it in context. This is big data. This is from 62,000 patients, okay, from the TVT database. This is big data. And it doesn't make a difference whether 1 or 2 or 3 were put in wrong, okay? And the presented at 2018 TCT showing worse outcomes with TAVR. So in other words, the TAVR PPM is not as low as you think it is. Severe PPM, and this is severe PPM based on a definition of 0.65, in 12% of all TAVRs and approximately 30% moderate PPM by a very respected researcher, Dr. Howard Herman. He's a cardiologist. So getting into that one question by the interventional cardiologist that we just talked to us, what about mechanical valves? Well, this was a New England Journal of Medicine article showing this excellent study showed that increased death with tissue compared to mechanical in patients aged less than 55, and the hazard ratio for AVR fell above the Unity mark at 62. So this is kind of an interesting thing. It really doesn't have much difference with TAVR, but it does have something to do with the mechanical valve question. So the guidelines are actually pretty sane, believe it or not, and they're based on data. These are the guidelines, European and American guidelines, and both of them are kind of recommending mechanical valves to patients under 60. You know, patients don't want this, but it's actually sane, okay, and based on data. And this is just a case I just did a couple days ago where I took out a big aneurysm in a mechanical valve 29 years later, and it was because the aneurysm, the valve, it looks like it was put in yesterday. So what about TAVR versus SAVR? What are the issues or nuances that would cause a pause regarding TAVR? Well, this is kind of like Dragnet, just the facts, ma'am, okay? And a guide to clinical decision-making for our patients, especially low risk, less than 3. So again, I use the same registry slide I just did before. So I just showed you some big data, TVT registry, about all the good things about TAVR. Well, here's a couple things that are a little bit worrisome as a person who's ahead of the TVT database and is worried about the entire patient population in the United States of America. And the first one is there's absolutely no change whatsoever between the very first TAVR that came out and now in stroke in the real world. None. Zero. Zip. Stroke rates are flat. No real change, very important if we're going into low risk. We're going to have a lot of data coming out very shortly regarding the cerebral protection devices because they are now in the database. And when you have a national database, we have 10,000 patients already that have cerebral protection. So we're going to have some really good data. It's going to be way better than any prospective randomized clinical trial. So what about pacemakers? Look at this. This comes out from the very first approval of TAVR in the United States of America. And absolutely no day. There's no difference whatsoever. These are flat pacemaker rates in the real world. We're not talking about the randomized trials. We're talking about the real world, mandated by law. 30-day, 11.8% new pacemakers, important as it is well known that pacemaker rates in young patients die earlier. There has been no change in the United States of America implanting community in 6 years. Also, there's a small but real catastrophic rate. Again, this is from the TVT registry, conversion to open heart surgery, cardiopulmonary bypass use, procedure aborted. And it's been pretty stable at about a total rate of about 2%. So this is still, these things still happen in the real world, which is probably the reason why we need to do these things in endo suites. So, more nuance. If you look at transcatheter aortic valve replacement for bicuspid valve, here's a meta-analysis, a typical meta-analysis. We'll go into the data. This is the editorial comment on that meta-analysis by Lars Sundergaard. Everybody knows Lars. He's a great interventional cardiologist from Denmark, one of the best in the world. Pacemaker rate is too high. This is 2018. Pacemaker rate is too high. Paravalvular leak rate is too high, at 12% and 18% respectively. So we're not quite there yet with bicuspid aortic valve. Don't put a TAVR in me if I have a low-risk BAV. I can tell you that much. So this was put out, and I actually agree with this, as I told you in my second slide. I love TAVI. But when you look at the kind of the reverse clinical decision-making regarding TAVR and SAVR, there's a box in here called the relative contraindication box. And this is poor TF access, age less than 65, bicuspid valve, coronary access concerns, which we talked about from the interventional cardiologist who was just here, pacemaker risks, and severe subannular calcification. So the point is all these go to the heart team and you make a decision. Well, I think in many respects, this group, and this is the reason why people need, both the heart team needs to know the data, many of those patients should go over towards SAVR. So my last thought. the concept of the 5-year crossover. This is something that our statistician just showed us, and I'm not a statistician, but I tend to agree with him. So let me just go through a few things. This is the 5-year Partner 1A data, which showed pretty good results out to 5 years in Lancet, and we have a composite endpoint of, but the composite endpoint of death or rehospitalization, or composite endpoint of stroke, TI, and death, all three of these trended towards favoring SAVR at 5 years, but their p-values were not 0.05. So it's all, but there was a major trend. It was kind of an interesting study, and I was an author on that study. I think Vino showed you this slide. This is the Partner 2 trial, and the ITT rehospitalization was significantly, very significantly positive compared to favoring SAVR in this group. And then, of course, as you saw, when you looked at the landmark analysis, the HR rate was 1.27, which actually calculates out to a p-value of 0.01, which was not put into the manuscript. And lastly, this gets into, again, what the statistician was just talking to us about. This is a very well-done propensity analysis, very recently published just a couple of months ago, looking at TAVR versus surgical aortic valve in a large registry. And you can see that, we're starting to see these 5-year data with data that is separating at the 2 and 3 year mark. It's becoming, you can see it all the time in all the studies. So low risk, this was a low risk trial, statistical crossover diversion at 2 to 3 years, and at 4 to 5 years was a massive difference. We need a big data linked study set. We need to link the big data sets between, in this country anyway, between TBT, STS, and Medicare, and the National Social Security Death Index to get hundreds and hundreds of thousands of patients. So my real last thoughts, what is required for future success? Know the data, important. This is the way you can best inform your patients and referring physicians. Quality is king. The BAV data, both the SAVR data and the TAVR data. TAVR data, and understand the nuances of pacemakers, AI, stroke rates, prosthetic patient mismatch, et cetera. Know what is not in the trials. SAVR data, recent trials that come out of the FDA and others. 5-year data on Kaplan-Meier curves. Establish a robust TAVR team and a clinic. Be a major part of it. It's huge. The entire AVR treatment pool has more than doubled since 2011. Remember that the AVR other category is expanding, so set up your aortic valve clinics, your multidisciplinary aortic valve clinics. The take-home message from this slide is not all these numbers. The take-home message is that the entire treatment of aortic valve stenosis is gigantic and increasing when you look at the whole picture. It's over 250,000. Thank you.
And the last talk of our session is actually extremely important for Dr. Fullerton, who is the Executive Director of the American Board of Thoracic Surgery. And he's going to talk to us about what is the appropriate training required for cardiac surgeons to achieve career success in treating patients with structural heart disease.
Thank you, Dr. Provenza, Dr. Shen, members and guests. I think it's fair to say that the current training paradigm in structural heart disease is somewhat superficial. It's inconsistent, it's very informal, and it's certainly not standardized. To this point, it has largely relied upon industry courses, some of which are very good, some of which are outstanding. It relies upon proctors coming into our individual operating rooms and institutions, primarily international meetings, such as the London Valve meeting or the TVT meeting or the EX and STS meetings, on-the-job training from peer to peer in our own institutions, and through unaccredited fellowships. Now today there's somewhere between at least 40 unaccredited training fellowships in structural heart disease that are based in cardiology programs, and since this slide was put together, I've learned of a few more. And there's about 10 that are based in cardiac surgery programs. Some of these do an outstanding job, but I think it's fair to say that one is different from the next. There's no standardized curriculum. Some are very superficial. And it's not clear what one learns or what can expect to learn going into any one of these particular fellowships. I do think that for the purposes of the procedure of TAVR, these various training paradigms have been effective to date. But I think they've been effective for a very simple reason. Number one, they've been focused on one procedure, and that being TAVR. And as you recall from the outset of TAVR's distribution across the United States, it was introduced to a population of experienced operators, both in cardiac surgery and in cardiology, who were simply applying very mature technical skills, advanced surgical and procedural judgment, with an understanding of the various disease entities that would be treated, all of whom, as operators, had extensive experience in patient care. And I think another important element that contributed to the success of this particular training paradigm to date was that all of the members of the team were learning a new procedure together and applying their particular aspect to a common good, if you will. However, I think going forward, a more formalized approach to the education of the next generation of professionals that wish to dedicate themselves to the treatment of structural heart disease is required. And it's for a couple of very simple reasons. Number one, structural heart disease is now a true subspecialty based within both cardiology and cardiac surgery. And it's not just about TAVR. And in fact, the procedural success of TAVR has catalyzed an explosion in new technologies and new procedures over the last 5 to 7 years that is expanding almost on a daily basis. Every valve, every cardiac condition, no matter what it may be, can soon be treated, or will try to be treated, through techniques that are applicable in the arena of structural heart disease. And therefore, it's a proposal from the American Board of Thoracic Surgery that formalized training in structural heart disease be established through the establishment of structural heart fellowships. These would offer the advantage of formalizing a curriculum in structural heart disease. The vision would be that these training paradigms would be multidisciplinary, training both cardiologists and cardiac surgeons in a faculty represented by all corners of the heart team. The rigor of these fellowships would be guaranteed through ACGME accreditation, and the expectation is that the graduates would become eligible for board certification in structural heart disease. The sorts of things that would need to be included in this sort of a curriculum include the decision-making and patient selection that's brought about through a heart team approach, through the valve clinics that we currently conduct. Formal education in cardiovascular imaging, which many of us as surgeons simply learn kind of on the fly along the way. But if you really want to do it well, it's felt that we could actually teach people this in a very formal manner, both in the diagnostic and the pre-procedural imaging, which is actually crucial to all structural heart procedures, as well as the intraoperative imaging techniques that are largely based in the cath lab. The procedural skills, some of which we gather as thoracic surgical residents, but most of which we have to learn through the various informal ways that I've described earlier. We have to learn how to manage the various procedural complications that can arise and deal with the nuance of caring for these sorts of patients following the procedure. There seems to be a consensus in the cardiology and cardiac surgery communities that the duration of training for these fellowships should be 1 year. And the candidates for training should be cardiologists who have completed an interventional cardiology fellowship or its equivalent if they have trained outside of the United States. And likewise, cardiac surgeons in the same program who have likewise completed their thoracic surgical residency or its equivalent if they have trained outside of the United States. Now, I think it's fair to say that there are advantages and disadvantages to this sort of an approach. And on the advantage side, the pros include that this is disease-specific training. It's not procedure-specific training. It preserves the concept of the heart team and all that that has brought to the care of cardiovascular diseases. Most of the knowledge and the skill sets that are required are common to both cardiology and cardiac surgery. And completion of this fellowship would lead to acceptance in all communities by virtue of board certification. On the other side, I think it's fair to consider what the cons may be, and these include the fact that it does advocate for an additional year of training. It does require a different mindset going into a multidisciplinary training paradigm. It is a new specialty, as I mentioned. There are more interventional cardiologists than surgeons, and the interventional cardiology community may view this as competition for the sort of procedures that they currently perform. And the fact of the matter is that virtually all surgeons leave a thoracic surgical residency with far fewer wire skills and imaging skills than our colleagues in interventional cardiology. Now, to this last point, it's a proposal from the American Board of Thoracic Surgery that the training paradigm in thoracic surgery mature with the inclusion of what would be considered a cardiac track in our thoracic surgical residencies. As you may recall, currently there are two tracks. There's a cardiothoracic track for individuals who are going to focus their career or want to be well educated in both cardiac and thoracic surgery. And there's a general thoracic surgery track for those who are going to focus their career in general thoracic surgery. The ABTS is in the process of developing a third track, which is referred to currently as the cardiac surgery track, the purpose of which is to provide the important prerequisite skills that a surgeon would require to successfully enter one of these structural heart disease fellowships. It's also important to recognize that after one has completed one's thoracic surgical residency or interventional cardiology fellowship, that said individuals don't want to lose those skills. They've worked hard to gain them. Now, during the fellowship, under current ACGME rules, fellows may spend up to 20% of their time during the fellowship either in the operating room or in the cath lab performing interventional cardiology procedures. So I think that's a way to preserve the skills that they've worked hard to achieve. This is a paradigm that I borrowed from Mike Mack that simply outlines a potential curriculum for an interventional cardiology trainee, training with a cardiac surgical trainee. And as you can see, each of these fellows would rotate through the different areas, whether they be interventional cardiology, cardiac surgery, or structural heart. They would obviously focus in the cath lab a little bit more for the interventional cardiology fellow, and in the operating room a little bit more for the cardiac surgeon. There's a variety of such curriculums that could be structured, but the point is that once these fellowships were established, the formalization would lead to a much more standardized product, if you will, along the lines of what graduates from our thoracic surgical residencies today. So in summary, I would simply offer that structural heart disease is now truly a subspecialty based within cardiology and cardiac surgery, and that the future requires formal training in a comprehensive manner. No longer will we as a group be able to rely upon the informal approach that we have relied upon to this point. It's true there are many details that need to be worked out, including how to navigate the need for additional training, cross-training across traditional lines of specialties. How do we finance these trainees, and the details of board certification from perhaps the American Board of Thoracic Surgery and the American Board of Internal Medicine. But I would argue that all of these things are doable. And I would finish by concluding that the way to prepare cardiac surgeons for professional success in the treatment of structural heart disease is with a multidisciplinary structural heart disease fellowship. Thank you very much.
Thank you very much. Maybe we could have all the speakers come up, and we'll have probably about 15 minutes or so for questions.
We can sit here. Tony?
So, gentlemen, I have a question for you, and I would like your really honest answer. I'm a 62-year-old male patient that happened to be a funder in your institution. So I carry a lot of weight. And I have already heard all your talks. I have read constantly what is out there. And I am in your office. I find out that I have my valve area is 0.8. My STS score is about maybe 1%, not even less than that. And really, I'm very, very much interested to see what you're going to do with me. So if you don't mind, each of you can tell me what do you think.
We go this way?
Yes.
Well, I'm 61. I think my risk is about 0.8%. And I also know the long-term data, which we didn't get into today. I would choose a tissue valve, surgical.
Okay. One thing that they didn't say is that anatomically I can have anything. So go ahead.
Yeah, I was going to ask you whether you're bicuspid, how big your aorta
I'm
was.
tricuspid, anatomically can have everything.
So, my recommendation is going to be most likely a tissue valve, but at least a 23. So not a small tissue valve, but at least a minimum of a 23. And if, depending on what your BSA is, maybe even a 25, but most likely, if you're a male or female, you never said if you're a male or female.
I said male.
Male, so most likely at least a 23, but it may do a root enlargement to put a 25 in you. And I would probably recommend most likely a tissue valve at that point.
Okay.
So if we all agree a tissue valve, then I suspect that patient will say, well, I'd rather have the TAVR then because I don't want to go through surgery. I would be okay with that, but I would want to have the discussion with them, what are we going to do with you when you're 75? And so to me, the anatomical considerations now are not just about that first procedure, it's about, do I think that you're going to be able to have a second procedure at 75, or are you going to have a more complicated surgery with explant of a TAVR? So I think the conversation and the analysis, particularly the CT, has to be more detailed and more in depth than we're doing now, because we have to start thinking about that second procedure now.
As the statistician in the room, I suspect with small numbers I'd want to do a Fisher's exact test, so I think I'll pass on.
That's a great answer. Probably the best one of them all. I think we do have equipoise here, and since it's a three-cusp valve, I would probably lean towards telling him I think he should do SAVR then TAVR. However, at 62 with a three-cusp aortic valve, if he really wants a TAVR, I would have actually no problem putting it in.
And I would agree with that. I'd recommend a surgical tissue valve, but I probably wouldn't argue with you if you wanted a TAVR.
I think the bottom line is look at the anatomy on the CAT scan. I know you said if everything fits, but you need to look at lifetime management, any concomitant CAD, any other, maybe if it's just isolated AS, if the patient can undergo future reintervention, I don't think TAVR is unreasonable. But if it's not feasible, then I think, and with a valve in the surgical valve is feasible, and I would definitely, like what Bino said, put a large surgical valve so that you optimize the hemodynamics and prepare for the next iteration, because this patient will either TAVR or SAVR will need a reintervention down the road, because we know even surgical valve will not last 20, 30 years.
The microphone.
Hi, my name is Jatin. I'm an I6 resident at Duke. Dr. Fullerton, I saw your talk last year at the AATS, and I will say I was really happy to see that, at the societal level, we're finally starting to come out with, discussion about the training pathways. I think for a lot of us, TAVR is very accessible, but all the new technologies that are coming, I think I can speak for a lot of the younger generation in training now that we don't really see a pathway for ourselves into the future. We don't really have an entry point unless you're at one of the few programs at Columbia or elsewhere where you have a mentor and you can kind of join a small niche. So just wanted to say thank you for pushing this forward. I think it's really good. And I guess my question is, how close are we to what you describe? I have another couple years of training, and it's something that I'm really looking forward to maybe getting to be a part of. And the second part of that question would be, assuming that doesn't happen, is there something that we should be doing, within the programs, are training people in surgery, to kind of open it up to applicants, like myself or others, so we actually have a formal pathway that we can enter into the training programs that allow us? Thank you.
Well, thank you. It's hard to know exactly when we'll be able to initiate this, but our goal is certainly within the next year. As you can imagine, anytime you come up with any new idea, and this is a new, somewhat different idea, if you will, there's a myriad of details that have got to be worked through, and we're kind of taking those one at a time as best we can. I will say, since the AATS meeting, we've had a series of meetings with many people that are in this room to begin plotting through that. We've engaged the cardiology community on a regular basis, as well as engaging the ACGME, the American Board of Medical Specialties, et cetera. So I'm optimistic that within about the next year, this will be formalized and in a reality. So we continue to work on it.
Dr. Fullerton, I was wondering, what is the reaction of the cardiology community and how they see this initiative?
I think it's fair to say that it's mixed. I think there are many leaders in interventional cardiology that are very enthusiastic about this. And it's also fair to say that there are some that have reservations about it. I think if the shoe were on the other foot, if you would, and the cardiologist came to us and said, we want to learn how to do surgical aortic valves with you guys, we'd have some reservations about it. So I don't think we need to be dissuaded by that. I think it's important to work together. I think all of us realize that the future of structural heart disease is a multidisciplinary future. And we have a professional obligation to our patients and to the population at large to do the very best we can as a profession. And this is a way to do that.
Yeah, that's a very important point. Microphone.
Okay. Euler Green from the German Heart Center in Berlin. What was stressed out in this wonderful session is when we are facing the decision-making regarding patients with AS, regarding SAVR and TAVR, and discussing different options, I struggle with one point of the PARTNER 2A trial, is that 23% had prior CABG in one arm and 25% in the SAVR arm. So a quarter, more or less, a quarter of patients had prior CABG. And now in all the years in residency, knowing what's the struggle in a reduced sternotomy, and even more if the bypass grafts are open, to do then a AVR. My question is, will there be, or is there a comparison in patients with single first sternotomy SAVR versus TAVR, or is this difficult to make afterwards because it's implemented in the STS risk score?
Yeah, so if I can just maybe rephrase that. So the question was there a comparison done of the TAVR valves versus those patients who had an isolated, straightforward primary AVR?
Just that, yeah.
Yeah, when we looked at the mortality, I actually wanted to mention this when you guys both gave your talks. The answer is that there is no major difference, because the patients who actually had a redo AVR previous CABG actually did better and almost had a 0% mortality compared to those who had a primary AVR. More of our deaths were in the primary AVRs than they were in our redo AVR. So having a prior coronary bypass, actually in the multivariable analysis, was protective, which I thought was interestingly enough. But I will tell you, this is important for what both of you said, the patients who were randomized in PARTNER 3 and PARTNER 2A, they weren't besides a coronary bypass, they weren't randomized to have a mitral valve procedure done. It was the surgeons who on the table decided they were going to throw a second valve in or they do an AFib ablation. They weren't supposed to. When they got approved on the cause, they were supposed to just do an AVR, not an AVR mitral valve replacement. So that was the surgeons who on the table made a decision to do that. So if we have to criticize anybody for those trials, for those concomitant procedures being done, it's actually the people in this room that should be criticized for that. And also remember, when you have in a New England Journal of Medicine publication, you can't just start throwing graphs on there. They're actually, you can only present the data for the primary endpoint. You can't start doing sub-analysis in a New England paper. That's actually prohibited by the New England Journal of Medicine. So we have to be careful about poo-pooing randomized trials a little bit, because that is the best data that we can provide. Maybe it can be tweaked a little bit, but I just would be careful about putting the same quality of level of data for randomized trials versus propensity matched trials.
If I could just make a quick comment. Two things. One, frankly, I'm a great fan of trials. It's what I do in my day job. We just have to make sure we do them right. The second point on the concomitant procedures, that's actually a very difficult question. If that's what happens in practice, then that's the fair comparison to make. That's the comparison that we want to make. If the opportunity to do the procedure leads to other things that benefit the patient, or can benefit the patient, then that might show to be worthwhile in the future. And maybe you don't get the opportunity to do those things when you do the TAVR insertion. So it's not so straightforward to say they shouldn't have been doing those things. Because if in the real world people are going to do them because they see a clinical need and an indication, we want them in the trials. We want trials that are relevant to policy. But no, we need trials, we just need high quality ones.
And we also want trials that are relevant to how we make decisions. The problem I have with the trial is that, in my opinion, those patients should have been excluded and more patients should have been randomized. Because the way we make decisions in real life is TAVI versus isolated AVR. When we bring in an AVR CABG patient, we're talking about should we do AVR CABG or should we do PCI? This was not a trial of AVR CABG versus TAVR PCI. So that's the problem I have, and I feel those patients should have been excluded. I also think the as-treated arm should have been the intent-to-treat arm because of the problems that Dr. Freemantle put forth about intent-to-treat. And finally, yes, the New England Journal only allows you to put in 1 or 2 graphs of the primary endpoint, but there were 8 years to publish those data. 8 years to tell the world that males were not non-inferior in the high-risk population. There was a confirmatory study that said the same thing, but it was never published. I don't have a problem. I do TAVI. I think it's a great thing, but I have a problem with what was presented and how it was presented and the things that were not presented. I think we have an issue with that.
Microphone.
Umran Ahmad from St. Louis, Missouri. So I was one of the fortunate young trainees that I was at a program where we were partners in one site, where I had investment from my attendings, largely through guidance at our meetings here, listening to our leaders who became the first hybrid surgeons turning to endographs. I pursued kind of an independent path to get training, including time in the cath lab. And what I found is that gave me a place at the table when the heart team began existing, that I could speak the language, I gained the skills I needed for it. But the idea of having the heart team and saying it was a 50-50 cooperation between us gave me a seat at the table where they were forced to listen, we were forced to cooperate, and I think we all grew from that. As we go to a separate certification for structural heart, are we in some degree surrendering our role? Where right now we're 50-50 with them, hopefully in most programs, or at least on paper we are. When we have a separate certificate, is it closing our door to what is a large portion of our practice? And then also, is the board looking at grandfathering people who are now experienced in training and what that looks like to make us board eligible as we're practicing now? Thanks.
Sure. Let me take the last one first. Yeah, I think that's a little easier. So the grandfathering issue is a very important question, and it definitely needs to be addressed. Each time the American Board of Thoracic Surgery or the American Board of Surgery has introduced a new certificate, they've incorporated a mechanism by which practicing surgeons could be grandfathered if they so desire. So examples, critical care. For example, I grandfathered into critical care board certification because I'd already finished my training when the certificate came and congenital cardiac surgery likewise. And so there's a series of examples, and this would likewise be one in which a grandfathering mechanism would be developed. To your first point, which is a very important point, and I think the board is looking at this from the vantage point of the generation of the cardiac surgery track, and I'll offer that this has not been finalized yet. What it will look like has not been finalized. The concept has been approved. But the notion would be that those that finished a thoracic surgical residency along the cardiac surgery track would finish with the sort of prerequisite skills that you acquired. They may not be identical to what you have, but they'd be in that genre, and would allow any graduating cardiothoracic surgeon to step into an environment and say, I can participate on the heart team and I can carry my weight. But there are also other surgeons that are currently practicing, perhaps you're one, but there's a growing number that are focusing their career in the arena of structural heart disease. And it's, I think the fellowship pathway is going to be most attractive to that group of individuals.
And has the board thought about including the actual structural heart training as part of that cardiac track? I mean, I think having them come out as someone who's already completed a structural fellowship, I think would be the ideal situation.
I think it would be ideal. The problem is that currently our residency programs are either 2 years, 3 years, or 6 years by and large. And when you look at everything that's required to be mastered in a relatively short period of time, there doesn't seem to be room to add on what would be required to come out as a bona fide structural heart guy. So hence the notion of the additional training.
Thank you. Dr. Guyton?
Robert Guyton from Emory. I've got two questions. First for Dr. Fremantle, because Dr. Reardon's not here anymore. With regard to the external validity of the trial regarding pacemakers, Dr. Reardon's claimed that the high-volume centers had a very low pacemaker rate, less than 1%, yet the overall pacemaker rate was 17%. That implies to me that many of the centers had a pacemaker rate in the 30 or 40% range, so they could average out for 17%. Doesn't that scare you with regard to the external validity of this trial and saying that in the real world, the pacemaker rate is okay for this patient, this particular device?
Well, if I can make a comment to that. Yeah, I guess the thing that I find most difficult with these data, with this literature, is the way things don't add up. I would really be wanting to see the well-designed observational studies saying complementary things to the randomized trials. And we don't seem to be seeing that. I certainly don't seem to be seeing that in the work that I've been doing. And that troubles me enormously. I think what we also don't have in this space, it troubles me, but it's always the case. I mentioned it in my talk. Manufacturers who sponsor trials always gain comparative trials. There's no question of it. Dr. Reardon himself referred to it. It's one of those open secrets. What we don't have in this space is a randomized trial that's sponsored by somebody other than a manufacturer with vested interest. Now, I've got no gripe with the manufacturers, but if there was another independent randomized trial sponsored by a non-industrial source, replicating the kind of results that we're seeing in the industry trials, I would feel just so much more comfortable. But, you know, let's think about the MitraClip. You know, where would we be now if the French hadn't sponsored MITRA-FR? We'd have a completely different view of the results. So I think we're still short. This is big technology. We heard about how important it is. We are really, really still short of data. We're looking at trials of a few hundred or even 1,000 or so patients when, you know, trials of beta blockers in heart failure had thousands and thousands, and statins, tens and thousands. But this is important technology. So,
but it's incredibly important that we have data on all of the TAVRs being implanted in this country, that we've got complete data in the TVT registry. I think that's a huge advantage.
Yeah, so
for
my
this,
question,
for this particular
but we've got a mismatch.
So my question to you is,
my
question to you is, as a statistician, is if you have huge data sets and you either use them raw or use them in a propensity analysis, a proper propensity analysis, where you're talking about a propensity analysis with 15,000 patients in it on each side, is that good enough is that better than a randomized clinical trial?
If you're asking me, I'm afraid size is not everything here. The difficulty is...
That's easy to say to Bavaria.
Yeah. The difficulty is that, well, actually, I see it in my work all the time. As soon as you've got times when professionals, skilled people like yourselves, make decisions about the treatment that patients receive, there's so much more going into that decision than I can capture on the data set that you give me. The judgments that you make that are based on years of experience and the training that you've received. And the challenge is that unless you randomize and you just flip a virtual coin to say which group they go into, if you allow people to make those choices can end up dominating the comparisons that you see. So the propensity score models are all going to be biased because there are decisions made about the suitability of patients for treatment A or treatment B.
I'm afraid we
have
really have
randomized
time.
trials which are also biased. That's the challenge.
If I could ask just one question to Dr. Bavaria. Why can we not use the Social Security Death Index to fill in all those missing deaths in the Partner 3 trial?
We can.
And
you mean for the Partner 3 trial?
Since it's supposed to be a partnership between government, industry, and professions, the absence of the Social Security Death Index just really bothers me, that we can't at least find out the mortality for those patients. Thank you.
I can't answer that question because that's...
You're chair of the steering committee.
I'm chair of the TVT steering committee.
It's your job to answer that question.
I'm chair of the TVT steering committee, and we can get the Social Security Death Index for that.
Dr. Chang, the last question, quickly.
There have been new standardized definitions for structural valve degeneration, and I was wondering if you could comment a bit about the Partner 2A reanalysis of structural valve degeneration between surgery and SAPIEN XT. I understand it didn't show a difference in S3, but XT suggested some difference?
Yeah, absolutely. So first of all, we as surgeons have done a very poor job in reintervention. Do you know what our reintervention is? When we call somebody structural valve deterioration generically in the surgical literature, you didn't have another AVR. You could have a mean grading of 100 sitting in your chair at home, can't walk to the refrigerator because you're so short of breath, your valve is completely stenosed, but if you didn't have another surgery done, you were considered with no SVD. So there's a big difference in how you characterize those. So in the cardiology literature, what it mainly is based on echo. Surgical literature is based on did you have a reoperation. So big differences between the two. And if you look at the Partner XT and you look at the surgery, there were more SVD overall in XT than there were SAVR. If you look at the cardiology definition, if you look at the surgery definition, there's no big difference because they didn't have reinterventions all the time. So again, it depends on which definition you look at. And I think we as a group have to come up, I think that more importantly, looking at the echo criteria, which is more stringent, is a better way to look at it than if they had another reintervention.
But we should probably be looking at our XT patients pretty carefully then.
So far at 5 years, at 83, it's hard to tell. When you look at the patients that are alive, it's okay. A lot of these patients get valve-in-valve, so it's a little bit easier if they don't have endocarditis.
Thank you, everybody, and this concludes the session.
Thank you.